time once again for Community Forum, and we are very lucky to have with us live in the studios this morning Dr. Philip Caper. Dr. Philip Caper has held professorships at Dartmouth Medical School and the University of Massachusetts Medical School, where he was also Vice Chancellor for Health Affairs, Chief of the Medical Staff, and Hospital Director. From 1971 to 1976, he was a professional staff member of the United States Senate Labor and Human Resources Subcommittee on Health, chaired by Senator Edward Kennedy. He is a founding member of the National Academy of Social Insurance, a founding board member of Maine AllCare, and a member of the National Board of Physicians for a National Health Program. And he is a regular monthly columnist for the Bangor Daily News, Maine's second largest paper, where he writes about health policy. Dr. Caper, thank you very much for coming in and spending time with us this morning.
Well, very happy to be here, Mike.
So start out, tell us about Maine AllCare.
Well, Maine AllCare is an advocacy group, which a nonprofit, which we founded about 4 or 5 years ago. And our mission is public education about the advantages of a universal single-payer healthcare system over what we have now. And we're working very hard to educate the public through community forums and through newspaper columns and letters to the editor and op-ed pieces and any other way we can get the word out. So we're really into sort of grassroots organizing at a local level, which in Maine, which has only 1.3 million people, is actually doable. And you can reach a large proportion of the population just by chipping away a little bit at a time at a community level. So we're focused intently on improving our healthcare system and bringing it more into line with what exists in most other wealthy countries, which we don't have now. And we'd like to see that happen.
So is the Affordable Care Act not enough?
No, it's not enough. And, I want to make very clear that I have tremendous admiration for the Affordable Care Act as a political accomplishment. It was difficult, as you probably know if you've been following it, to get passed. It passed on a strictly partisan vote in the Congress, and it passed by a very narrow margin, extremely narrow margin. So I think it was a great political accomplishment. But as a piece of public policy, I think it's pretty messy. And people are finding out about that as they are now required to pay more attention to the healthcare system because most people are now required to have health coverage or pay a tax penalty if they don't have it. So the best thing it's done, I think, is to destabilize our existing very dysfunctional system of healthcare. And but beyond that, it's pretty messy. It's way more complicated than it needs to be to get the job done if the objective is moving toward healthcare coverage for everybody. And that complexity introduces, first of all, it costs a great deal of money. In many states have just poured a lot of money down the drain trying to set up exchanges. For example, Oregon, right next door, has now abandoned its efforts to set up their own exchange, and they're going with a federal exchange. But in the meantime, they spent about $500 million trying to set up their own exchange. Massachusetts, which was the forerunner of the affordable health care, had an exchange that worked pretty well until the affordable health care kicked in. And now their exchange has blown up because of the additional federal requirements, and they're going to go with a federal exchange because they can't make theirs work. And so the complexity is expensive not only in terms of dollars it costs and the aggravation it brings to patients and doctors with all the complexity, but also it costs a great deal in terms of public support, because most people, in fact, I'll say very few people really understand what's in the Affordable Care Act. It's way too complicated. And with that complexity, if people don't understand it, they won't support it. So I think it's going to be impossible to ever generate really broad-based majority support for the Affordable Care Act because people don't understand what's in it. If we had simply expanded Medicare, for example, to include everybody, maybe incrementally over time, lower the age of eligibility by 1 decade every couple of years, we would have had a program that I think would have been broadly popular with the public. Don't forget, when Medicare was enacted, it's almost 50 years old now. It'll be 50 years next year. They were able to enroll 19 million people in 9 months using index cards as a way of collecting information. No websites, no computers, because there were none, but it was a simple, you checked one box. Either you wanted in or you didn't. And that was the end of it. No prior health history, no who's your employer, no what's your income. All of that was gone because it's a universal program. So most of the money that we pay into Medicare actually goes for medical care. Much of the money, in fact, almost half of it, we pay into the Affordable Care Act is going to go to administration of one sort or another. Checking people out, deciding what network they belong to, deciding what services they're covered for, deciding how much out of pocket they pay. All of that costs money. And it's, as far as medical care is concerned, it's just money going down the tube. So we would like to see the Affordable Care Act greatly simplified and expanded to include everybody. It's actually cheaper to cover everybody than it is to spend a lot of money deciding who not to cover, which is what we're doing now. We want to make this is a peculiarly American trait. We want to make sure nobody gets something they don't deserve, however we define deserve. So we spend a lot of time, effort, and money trying to figure out, make sure nobody's getting something they don't deserve, according to the terms of the law. All that costs a lot of money. And there's going to be a lot of errors in those determinations. So all in all, the Affordable Care Act, while it certainly does do some good things, it expands coverage for a lot of people, it reins in some of the more the worst abuses of the commercial insurance industry, it doesn't remove the incentives to continue finding ways to abuse the customer by the commercial insurance companies. So we view it as doing some good things, but a long way from where we need to be.
So how do you see us going from what we have with the Affordable Care Act to a universal health care program?
Well, I think it's unlikely that there will be much significant change at the federal level, because you can see how contentious the Affordable Care Act has been and how much political dust it's kicked up. And if there's one thing politicians know how to do, it's how to avoid pain. And this is a very painful law for them to deal with. So they're not going to be terribly anxious to go back to this anytime soon. However, there is a provision in the Affordable Care Act that allows states to do their own thing. Beginning in 2017, there was a provision called the State Innovation Waiver provision, authored by Senator Ron Wyden of Oregon. And that essentially says if a state can improve on the Affordable Care Act, can do their own thing, and it costs no more than the Affordable Care Act would cost, and it provides at least as many benefits, they can essentially waive most of the provisions of the Affordable Care Act, including the mandates on individuals, including the mandates on businesses, including the tax penalties. All that stuff goes away if a state can do something better, what it says. And I think you're going to see quite a few states trying to do that when 2017 rolls around, when they've had a little more experience with the Affordable Care Act and more people recognize its shortcomings. And one of the things we're doing at Maine AllCare is to try to educate the public to that possibility and saying, we can do better. Because in most wealthy countries, their healthcare systems cover everybody. I mean everybody who's a resident of that country. They have better outcomes. There was just a report issued last week or a couple of weeks ago by the Commonwealth Fund that shows that of 12 industrialized countries studied, the United States is first in only one parameter, and that is how much money we spend by a long shot. We spend almost twice as much per person as the other countries do on average. But we are almost dead last on most of the other measures of quality, of access, of fairness, and other things. So we want to educate people that there is possible to do things in a much better way. So other countries get better outcomes, cover everybody, have systems that are more popular with the politicians, with patients and the general public, and with the doctors than ours. And oh, by the way, cost about half as much as ours does. So, you have to ask yourself, what's wrong with this picture? What are we doing that other countries are not doing that's resulting in higher costs and much poorer performance across the board?
So who is really making all the money in our current system? Is it the pharmaceutical companies?
Well, it's ironically, I mean, it's everybody but the people actually doing the work of providing health care. There was an interesting article in Time magazine about a little over a year ago by Stephen Brill called Bitter Pill. And he sort of dissected a bunch of hospital bills and asked, where's all the money going? Much of the difference in spending is accounted for by higher prices here, including doctors' fees, I have to say. But more importantly, the corporate profits are much higher. For example, pharmaceuticals cost much more in this country than they do in any other wealthy country. And that's because in other wealthy countries, the government negotiates prices with the drug companies. In this country, we can't do that. Even our public program, Medicare, is prohibited from negotiating prices with the drug companies by the Congress. And so that's one issue. The money is being made by the business people in healthcare, the people who are now running the large healthcare delivery system, the corporate executives, the corporate shareholders are doing very well in the pharmaceutical industry, in the medical device industry, and in these large, particularly the for-profit hospital systems. Companies, like Cancer Centers of America is a for-profit oncology chain, and they're doing pretty well by convincing people who have cancer to come in, and you get a second opinion from them, and they then prescribe expensive medicines, which are pretty high margin medicines. So in this country, while we don't have good access to primary care, that is your family practitioner, your pediatrician, whoever, we have excellent access to profitable services. So we have a lot of MRIs and CAT scans. We have a lot of surgery centers. We have a lot of services that provide high profitability. So what we really have is a money-driven system. And as a physician, that bothers me a lot. Because medicine, we take the Hippocratic Oath when we're sort of sworn into the medical profession. And the Hippocratic Oath boils down to put the patient first. That's it. That's the essence of the Hippocratic Oath. Do no harm, put the patient first. And unfortunately, doctors are now more and more becoming corporate employees. There's a vanishingly small number of doctors who are still in practice entirely on their own. And when you're a corporate employee, you march to the orders of the corporation. And the corporations are run by business people who are looking at the bottom line, which is that's what they do. And so the doctors are now sort of caught between the demands of their corporate employers and their own Hippocratic Oath. And it's causing a lot of heartburn on the part of many doctors. And I think accounts for the high burnout rate among physicians nearing retirement age. More and more of them are just saying, our best days in medicine are over. Let's just get out of it. And that's a big problem. So I think that, the United States is unique in that it's the only wealthy country in the world where healthcare and medicine is considered to be a business. And that transition happened during the late 70s and early 80s. It was given a jump start by the Reagan administration when they, all of a sudden it became okay to be rich. There's no shame in being rich. It was a great thing to do. And lots of doctors and others began getting MBAs and, we're going to be businessmen. What they didn't seem to understand at that time is that the fundamental mission of a business, any business, is to create wealth for its owners. That's it. That's what they all have in common, and that's what they should do. And in fact, that's what many of them are required to do by their state corporate charters. Maximize profitability by any and all legal means. That's it. But that shouldn't be, in my view, the primary mission of a healing profession. It interferes with the healing, and it destroys trust by the patients in the healers. You go to your doctor and you think all you are is an ATM to them. It's going to actually impair the healing process because you won't trust the healer. Medicine is still a relationship business. It's not a business about technology. We use technology, but it's fundamentally a business about relationships. And because of the financial pressures on physicians now, we can't spend more than 10 or 15 minutes with a patient. We have to turn patients over, do volume to get the fees in. And that itself really impairs our ability to do our job. And that, I guess, is what bothers me the most as a physician about what's going on here. So we have some fundamental I call it the underlying pathology of our healthcare system. All the other stuff, the large number of uninsured, the high cost, the spotty quality, those are all symptoms. The underlying pathology is treating medicine as a business and relying on commercial health insurance as a way of financing it. Because the health insurance companies, if they're for profit, particularly if they're publicly traded and worried about their stock price, is a bottom line business. It's like a bank or a credit card company. And that's, they may do healthcare services, but their primary mission and legal obligation is to maximize profitability. And that interferes with the healing mission of medicine and other healing professions.
So that sounds like a paradigm that's going to be tough to crack at the state level.
Yes, it is. Well, I'm not so sure. It may actually be easier at a state level in some states than at a national level, because this is a pretty heterogeneous country. Texas and Maine and Washington State and Oregon and California are very different cultures from one another. And for example, Vermont has already passed a law saying we intend to go to a universal, publicly financed healthcare system on a state level within 4 years. And they've set up a commission to say, how do we get from here to there? So they already have the political climate to achieve this, which is not the case in a place like Alabama or Texas, for example. Take Oklahoma to take a few examples. So it may be, that's why I think it's more likely to happen on a state level than on a national level. And I think once a few states have shown that they can do it and are getting better results, have everybody covered, and spending a lot less money, I think it's going to catch on. That's the way it happened in Canada. Canada started out with Saskatchewan, one province, enacting a universal health care system back in the mid-'60s. And within 10 years, it had spread across the entire country. And now it's essentially untouchable. I mean, no politician will admit they're trying to subvert the Canadian system if he wants to keep his job in Parliament. It's that popular with the public. Nobody is going to admit, even though there are attempts to do it, they're calling him something else. And part of that popularity, I think, is because in a universal system, which is what we're advocating, everybody has a stake in it, in the same system. Okay, in our country, you have commercial insurance, you have Medicaid, you have Children's Health Insurance Program, you have Medicare, you have the whole system is so fragmented that people don't have any a common interest in a single system. And I think that's a very important element for this political sustainability of a system. And so we end up with people fighting among themselves. The young people are fighting the old people, and the rich people are fighting the poor people, and so on. And I think that is a big cultural shift. But it's what we have to do if we really want to have a healthcare system that works. And our healthcare system now doesn't work on many, many levels. too expensive. It's too fragmented. The ACA, Obamacare, is patently unfair, both in the way its benefits are distributed and in the way it's financed. There are some people who are too poor to get any help. There are some people who are too rich to get any help. There are people who are in the middle. For example, in the states like Maine that have refused to expand Medicaid, which was an important part of the Affordable Care Act, you can be too rich to get any to be on Medicaid, but too poor to qualify for help from the Affordable Care Act. There's a whole group of people that are very close to the poverty level that get no help at all, while people wealthier than they are get federal subsidies for their health insurance. If you make more than about $45,000 a year, you get no help from no subsidies on the exchanges. But you're continuing to pay taxes to subsidize health insurance for wealthy executives who are getting a federal tax break, because health insurance, if it's linked to employment, is tax exempt. So you're paying taxes to make up for the taxes the wealthy executives are not paying because they have employment-based health insurance. But what's fair about that? Nothing. So there's a lot of work to do. The Affordable Care Act absolutely does some good things, but we have a long way to go, and we could do a lot better.
So sticking with your state of Maine, what plans do you have then for the short and medium term?
Well, we're working. I've worked around politicians most of my career, and I understand that they cannot get too far ahead of their constituents in terms of their understanding of an issue if they want to keep their job. So our focus is on changing the public environment and understanding of this issue. And we have bills in the Maine legislature. We actually got one through the legislature this past session to set up the first step in moving toward a single-payer system in Maine. Unfortunately, it was vetoed by the governor, our Tea Party governor, and we couldn't override the veto. But we're going to try to get that legislation through next year, when hopefully we'll have a better governor. He's up for re-election this year, and hopefully he will not be there for very long. And we're going to try to get something through the legislature. Failing that, we have an initiative and referendum process in Maine, so we can go directly to the public, and we will do that if the legislature is unable to do the right thing.
And what would that first step entail?
It would set up it would do what Vermont did. It would set up a study to get some actual information about how one approach compares with another. And what Vermont did and what the bill we passed did would require the legislature to fund studies of three approaches, one of them being a single-payer approach. And look at the costs, look at the benefits, look at where the money goes, and come up with some information, which could then be used as a guide by the legislature to craft legislation actually creating the system. That's what Vermont did. And they did their study. They commissioned a study that was done by Professor William Shao of Harvard University, and they picked the single payer as being the best alternative. But that followed about 9 years of grassroots organizing. So there was a lot of preparation of the public. Now, Vermont is even smaller than Maine. Vermont has 100,000 residents, so that's a pretty tiny place. But they sort of blazed the pathway, and we're following that with our 1.3 million people, and we're hoping to have the same result. They did such a good job that in the gubernatorial election back in about 2010 or 11, they had competition among the Democratic candidates for governor for who was the most single payer, who was the most in favor of single payer. And Peter Shumlin ended up being the most in favor of single payer. He won the election, and he was able to get the bill through their legislature. And they're now going through the process of figuring out how we get from here to there. Now, there's a big stumbling block. There's a big obstacle, and that is that a publicly financed and controlled system is going to require a significant hike in taxes. And you can call them whatever you want to. You can call them premiums or contributions, but they're taxes, let's face it. And taxes are not very popular in the United States. So when Governor Shumlin is accused by his opponents of promoting the largest tax increase in the history of the state of Maine, he said, well, I don't look at it that way. I look at it as the largest premium decrease that's ever been given to the people of Vermont. I'm sorry, not Maine. And he is being successful in getting that message across. People understand that total spending will go down, even though some of it, funded by taxes, will go up. What you take home in your paycheck is going to go up, because the taxes will be less than people are now paying through a combination of premiums, out-of-pocket expenses, and the other miscellaneous nasty surprises anybody who tries to use the healthcare system is in store for. So, and people are now, because of the complexity of the Affordable Care Act, because when you find that once you buy a plan on the exchange, you're still going to have a large outlay, out-of-pocket expenses associated with that, because the way they keep the premiums down is to increase the cost sharing at the time you use the services. So your policy is fine as long as you don't try to use it. But as soon as you try to use it, you're in for a nasty surprise, because you're going to be still left with large coinsurance and deductibles out of pocket. And you're going to find that some of the doctors and hospitals you've been used to using are not in the networks, because the insurance companies keep them out to try to keep their premiums low. And it'll be interesting to see how Americans who love the idea of choice respond to that. I mean, I personally don't think anybody cares who their insurance company is. I think they care a lot about who their providers are. So when you go to the exchange to choose among insurance companies, I think people are apathetic about who the insurance company is, but they care a lot about whether their doctor is in the network or not. And I think they're going to find that that's a trade-off they're not going to be willing to accept.
Right. Just about 2 minutes left. So the ACA has protocols in there for Vermont to make that leap that they're attempting to do?
It has a provision. I think it's Section 1332, the state innovation waivers. And they can get a waiver from the federal government to do their own thing, as long as it's at least as good as and doesn't cost any more than the ACA. And that's a pretty low bar, given what's going on and all the money that's flowing into the system that has nothing to do with medical care. We should be able to do that pretty easily.
All right. We are talking with Dr. Philip Caper. He is a founding board member of Maine AllCare and a board member of Physicians for a National Health Program. And you are one of the featured speakers tonight at the Healthcare is a Human Right, Making It Real in Washington State event that's happening at 7 p.m. Kane Hall 120, the University of Washington campus. It's the Physicians for National Healthcare Program Western Washington Chapter annual meeting. So.
Right, and that's I should say Maine AllCare is the main chapter of Physicians for National Health Program. So we belong to the same national organization as PNHP of Western Washington does. So I'm here visiting a sister organization. I'm very happy to be here.
All right. So people want to hear more from you and find out more about your national organization, then tonight's event is a good venue to do that.
Right. Or they can go to the pnhp.org website.
Okay.
And I actually just created my own web page, which is philcaper.net, and that has a link to my articles and to a healthcare clippings blog that I produce periodically, and to a lot of other interesting articles about this topic. So if anybody's interested in getting more information, those are some good places to go for it.
All right. Well, with that, we are unfortunately out of time. I want to thank you very much for coming in and spending time with us this morning.
Well, it's been a pleasure. Thank you.